You're listening to the Future Tech Health Podcast with Richard Jacobs. Until I reached age 40, I never realized the obvious, that we all have medical issues, or we at least have a family member or close relation that has, or will have them in the future. Medicine and biological systems are the final frontier. Until we've conquered death, figured out how life began, cured cancer, and understood our purpose in the universe, there's a heck of a lot to talk about when it comes to our health. Future Tech Health means I'll be covering futuristic topics that are actually already in clinical trials, or even starting to appear on shelves or by prescription, or available for your own use. We dive deep into stem cells, CRISPR-Cas9, the science of sleep, epigenetics, medical testing, cancer, ketogenic diets, stem cells, aging, regenerative medicine, and more. My goal for you, the listener, is to learn from these podcasts. You may very well learn something that may change the course of your life for the better, steer you towards a new career, or give you insight into addressing a serious medical problem. Remember, however, this podcast and its content is informational in nature only. No medical, tax, legal, financial, or psychological advice is being given. If you enjoy the podcast, please listen, subscribe, like, and share it with friends. Thank you.
Hello, this is Richard Jacobs with the Future Tech and Future Tech Health Podcast. I have Dr. Hindin. He's a dentist. He graduated from New York University College of Dentistry. He's trained in general dentistry, but also an emphasis on surgery and endodontia. He's also worked in the area of cosmetic dentistry, temporal mandibular joint disorders, TMJ, and craniofacial pain. So, Howie, thanks for coming. How you doing?
I'm doing well today. I'm happy to be here. I'm excited about doing this podcast with you.
Oh, good. And I know you're not just a traditional dentist. Where have you gone with your knowledge base, and what areas of dentistry have you settled in that are not your typical?
Okay, so my journey has taken me to a lot of different places, but where I am now in my life after 53 years of being a dentist, I'm still in practice, but I run two organizations. One is the American Academy of Physiological Medicine and Dentistry, APMD, and I'm also the founder and director of the Foundation for Airway Health, and that's my interest and passion, and that's what I would love to be able to talk about today.
You know, it sounds like, it sounds like it'd be a simple thing. How could there need to be a foundation for airway health? What's involved in it?
Okay, so let me tell you a little story of how we got started. About 10 years ago, one of my friends, Dr. Michael Gelb, his father was actually one of the pioneers in TMJ. We were talking about we should never have to see the patients we see. We do a lot of TMJ, sleep and airway problems. And so we decided to let's start an organization, let's start a foundation, let's write a book about it. We wrote a book called GASP, which is a book about the hidden airway problems. And so we started the APMD, and the APMD was meant to be an organization centered around airway. And we said airway is more than sleep, because if somebody's not breathing well at night and it's affecting their sleep, they're also not breathing well during the day. And we wanted it to be an inclusive organization that any practitioner who had anything to do with airway, be it a physician, dentist, physical therapist, speech language pathologist, nutritionist, could all have an equal seat at the table. And that was about 9 years ago. Fast forward to where we are today, we've created our conference around a theme called Collaboration Cures, meaning that we think that the health problems of today can best be solved by collaborative care. So if I told you that we have a growing epidemic of chronic disease, poor performance, growth and development problems, and learning issues, you probably wouldn't be shocked about it, especially in the United States, where we're number one in healthcare expenditures and about 14th in the world as far as the health of our population. that wouldn't be surprising. The thing that you might not be aware of is they now believe that a lot of these chronic diseases can be prevented and even reversed, but not by any one pill or treatment or medication, but by a collaborative approach focusing on personalized medicine. So if you think about cardiovascular disease, there's work done by a cardiologist, Brad Ball, and others who now have a way to reverse cardiovascular disease. Also, a researcher, a physician, Dale Bredesen from California, wrote a book called The End of Alzheimer's, and he has now reversed Alzheimer's in over 500 patients. Not by any.
Before we move on, it makes total sense to have a team of medical people with different specializations helping you when you're sick. But this sounds like it's beyond that. So how did Dale Bredesen reverse Alzheimer's in people, to your understanding, and how did the other doctor you mentioned reverse cardiovascular issues? Like, what are some specifics?
Okay, so let's talk about Alzheimer's. So what Dr. Bredesen, his belief is, and he calls it 36 holes in the roof. He's identified 36 reversible causes of Alzheimer's, including nutrition, toxic materials, hormonal imbalances, poor relationships. Everything affects the brain. And his belief is Alzheimer's may not really be a disease. It's that our brains get overwhelmed by the load of our lifestyle. And they say, look, our brains say, I can't deal with all the stuff that I have to deal with. I have to keep breathing. I have to keep my heart beating. I have to make sure I keep my temperature regulated. I can't do everything. I'll dump some memory. And it may be that the plaque that forms in the brain of Alzheimer's may be an attempt to put a bandage on a wound, just like the plaque in arteries is like a bandage. So the important thing for dentistry is there are several issues where the dentist plays a key role. The certain bacteria in the mouth called P. gingivalis is a bacteria that's very common in periodontal disease. And it's the same bacteria that's found in the atherosclerotic plaques of people who have cardiovascular disease, and the same bacteria that's found in the brain of Alzheimer's patients.
Oh, wow.
And there's only one place it could come from. It's from the mouth. And so the belief is that if you have that bacteria and there's not a good barrier that keeps it in the mouth, like inflamed gums where the barrier breaks down and there's pocket formation, that barrier can get into the bloodstream. If you couple that with a sleep airway problem, and it's completely accepted that if you have a sleep problem, then you have a greater level of inflammation. So now the same amount of bacteria that may not cause as much of a problem in somebody who doesn't have a sleep problem is going to have much more of an effect, because anybody who has a sleep problem is going to have an altered immune system. By the same token, if you have different materials in your mouth, like mercury or nickel or other materials, you add another burden. And we're only talking about the dental arena. Now, if you add nutritional problems or with sugar and other things, you can see how the total load begins to build up.
That makes sense. If you don't mind, can we focus on the dental arena, because that's not a lot of people have knowledge about those specifics, and I'm sure you do.
Absolutely.
So the questions that came to mind, if I have a mercury filling from 20 years ago, is that still leaching mercury into me, or is it fine? What's your experience and opinion?
So the answer is it may or may not be, because filling that's put in at some point in time will leak, but the amount of mercury that leaks out will be slower over a period of time. However, there are other factors. If your mouth tends to be more acid. It will leak more. If you have other materials in your mouth, then there will be the battery-like effect. So, for example, you have a mouthful of mercury fillings or a few mercury fillings, and then something breaks down and you have a crown put in that's a different metal, and your mouth is acid. Now you'll have a battery-like effect between the two different metals, and the mercury will actually leak out at a faster rate.
Huh, that's really interesting.
So now,
what other metals are they using now for crowns and fillings and stuff? What is the most modern things they use?
Well, being an older person, I remember the days where it was just silver and gold were the choices. Now, a lot of dentistry, and in our practice, we only use zirconium or ceramics. So we don't use any metal in the mouth. We don't want to put any metal in people's mouths. And being aware of the different ways that metals affect each other. When the price of gold began to really go up years ago, dentists started using more of nickel, and nickel is a very toxic metal. It's good for dentistry. It's easy to work with. It gives you a durable result, but it's not a really biocompatible material. And if you put nickel and mercury in the same mouth, that's really not a good situation. Then the way this collaboration works is if you also have certain genetic alterations. There's something called the APOE4 gene, that if you have a certain variation of that gene, you're going to be a poor detoxifier. Or if you don't sleep well, you'll be a poor detoxifier. So you're going along, and all of a sudden something breaks you, or you're grinding your teeth because you're not sleeping well. You break a tooth, you get a different type of metal in your mouth. All of a sudden you have more mercury leaking out, and you have a sleep problem, and you have a genetic alteration. That's why we always have to get back to the collaborative effort, and you have to be able to think. Even though I'm a dentist and I focus in the dental arena, I need to think about what else is going on and who else needs to be a partner for this particular patient in order to get optimal care.
Yeah, no, it makes sense. There's a whole big conversation on, why medical people either collaborate or don't collaborate, and how people are siloed into their specialties. We won't really get into that because it's a whole, again, endless conversation. But you talked earlier about airway health. What's involved in airway health? How can people breathe right or breathe wrong? What can happen with the airway to cause them problems?
Okay, so the whole field of airway sleep medicine and obstructive sleep apnea is probably somewhere between 50 and 75 years old. So it's a relatively new branch of medicine and dentistry, because dentists play a role in that. And the disease is called obstructive sleep apnea. And the concerns are what can happen, and you can be tested for it. You can go into either have a home test or have a test in a lab, and they measure the number of times you stop breathing for 10 seconds or more, which is obstructive sleep apnea. But if you are sleeping at night and your airway begins to close, and it doesn't close all the way, and then you wake up, or you don't wake up fully, you just aroused to a state of sleep below wakefulness, and it doesn't count as an apneic episode. And if you don't have enough apneic episodes, then you don't have a diagnosis. But whether you have apnea and you stop breathing, or whether you have what they call hypopnea and you're breathing with more resistance, or you have an arousal, the physiological effect on your body is exactly the same. So even though you may not get a diagnosis, you could have the same physiological effect. So if I can give you an example of what happened.
Well, I think I have one example. So if I'm in the stage of my sleep where I want to be in deep sleep for the next hour, but because of my breathing, I come out of deep sleep, 30 times in that hour to a light sleep stage, that essentially kills my deep sleep and would hurt me physiologically, right?
Right, because when I was a kid, I always wondered why we're going to spend a third of our life sleeping. Seems like an awful waste of time, but what we do in that third of our life will determine how good the other 2/3 of our life are. So when we're asleep, we consolidate memory. Our immune system repairs itself. Our body slows down. We get rid of waste. There's this whole wonderful process of cleaning up all the day's activities. It's sort of like the restaurant is dirty at the end of the day, and then in the morning, at night, the crew comes in, and the next day, everything is open and everything is bright and clean and ready to start over. If you don't get the deep sleep, you may be tired during the day. And the most important thing about these airway problems is you don't know it. You don't know how you're sleeping or not sleeping. That's why we call it the unrecognized or hidden airway problems. If you are screwing up your diet, you know it. If you're not getting enough exercise, you know it. But if you're not sleeping, you have no idea how the quality of your sleep. An example that you just gave me, if you're not going to deep sleep and you rise up to a state just below wakefulness, you don't know that you're doing it. All you'll know is you said, I don't feel rested. So what do? You have a cup of coffee in the morning and you get yourself going so you can be ready for to do an exciting interview, and you don't think about it. But day after, even one night's poor sleep changes your immune system, increases chronic inflammation, affects brain function. But if you add days in a row, weeks in a row, months in a row, we believe that the seeds of dementia and Alzheimer's are planted 20 to 30 years before any indication of that disease occurs.
You mentioned also airway problems during the day. What would those be for people?
So if we're talking about at night, if your airway closes and you don't breathe, people during the day, when they relax or they don't pay attention, the same thing may happen. One indication of that is people who sigh a lot. All of a sudden, the airway begins to close, and all of a sudden you take a deep breath or you sigh. That's an indication that the airway is closing. Whenever that happens, you get this spurt of adrenaline. And people who have an ongoing airway problem tend to be adrenaline addicts, meaning they need to be in an adrenaline state. So they live their life needing an adrenaline fix. So, for example, if you're an adrenaline addict and you can comfortably do 3 things in an hour, you plan 5. You always need to have an edge. You choose to work in a difficult job. You choose difficult relationships because the way that you keep your airway open is by getting that adrenaline fix. So the way you know about it is 1, you sigh a lot. 2, are you an adrenaline addict? If I was to say to you something like, I'm going to give you a gift, a week's vacation on the most beautiful beach, and all you have to do is do nothing, lay on the beach and do nothing for a whole week. Does that make you uncomfortable or comfortable?
Yeah, I would hate that. But then again, I don't think I'm an adrenaline junkie, but I would hate to sit there and do nothing.
Yeah, but then the people who I don't believe they are, but people say, well, can I read a book? I said, no, you can't read a book. Can I jog? No. And so people who have that issue don't want to do nothing. They always need to be doing something. They need to be doing several somethings at the same time. And so, in Chinese medicine, they talk about yin and yang and the balance of going out and doing things and coming back and repairing. And so we have a deficit. It's like we're overspending on our health credit card. And people who are doing that are usually very successful. They're usually high achievers, and then something happens and they break down and they say, well, I was okay yesterday and now I'm not. It must be something that happened in the last 24 hours, but it's not. It's something that happened over a period of years. You could predict who are the people that are going to have are going to have problems. And, for example, if you're not sleeping well, you're going to crave more caffeine, you're going to crave more sugar. That throws your whole cycle out. When you go to sleep at night, we're supposed to turn off our daytime neurotransmitters, which are epinephrine and dopamine, and shift over to melatonin, GABA, and serotonin. And there's a beautiful cycle that goes on. Our blood sugar is higher at night, then gradually falls in the morning, and we get up and we're ready to go out and hunt and gather like our ancestors do, or go to work. But if our sleep is altered, we'll get spikes in our blood sugar at night. And people who are diabetic, their blood sugar is usually the highest in the morning. We see patients who will say, I'm taking medication, my diabetes is under control, except for the morning when that seems to be higher. But when their sleep is treated, that can come under control. In fact, that we have seen many patients who, when their sleep is treated, they're able to reduce or get off their medication. So in dentistry, if you have a sleep problem, what are the choices? A CPAP, which is a mask wear over your nose, a dental appliance, which is good for mild to moderate sleep apnea, surgery, which is rarely effective, and now they have a new thing where they have these implantable devices that it's almost like a pacemaker for your tongue that keeps your tongue out of your airway.
The hypoglossal nerve stimulator, the tongue shockers.
Yeah, the Inspire medical implant, which is certainly great for children who have Down syndrome children, the people who wouldn't be responsive to other treatments. Really made a huge difference in that particular patient population.
Well, so, I've spoken a lot about CPAPs and oral appliances and, even a little bit about the hypoglossal nerve stimulators, but how effective are those treatments? You have to also address, like you talked about collaborative medicine, the diet and other aspects just as critical to getting a good result, or are those devices enough to fix people?
Okay, so in my view, the one of the big problems in medicine, if you have a problem and you do a CPAP or you do an oral appliance, you'll be better. And if you're better, the practitioner is happy, pats himself on the back. Patient is happy, I'm feeling better. But have you achieved an optimal result? That if somebody has, let's say, an AHI, a sleep score of 40, and they wear an oral appliance of CPAP, and it's down to 15. Say, wow, look what a great result we've got. We've cut it by more than half, but it's shown that you're not going to really make an impact on the factors of blood pressure, diabetes, unless you get it down under 5. You really get it down lower. And so should you stop there, or should you say, I've done my role, maybe I need to get this patient in the hands of an integrative physician who can look at diet and maybe help lose some weight, because weight loss is another way to improve sleep and breathing. Or one of the compensations for poor sleep and airway is a head forward position, because when the head is in a forward position, the tongue comes forward and it opens the airway. So patients adapt this head forward position with rounded shoulders, and they tend to breathe more from their upper chest, and they don't use their diaphragm enough, and they tend to have neck pain because they're using the accessory muscles of the neck in order to breathe. You help them.
Hallie, one quick second. So from your descriptions, it sounds like the drive and the hunger to breathe is so great, it can cause people to, in one example earlier, have drama-filled lives or have, be adrenaline junkies. And you're saying also physiologically it can cause them to change their posture and their breathing, and their whole body, their whole way of doing things changes because of this hunger to breathe better?
is there anything more important? Is there any physiological need that is greater than the need to breathe? We can go without food, we can go without water, we can go without a lot of things. We only have a few minutes without air or we won't survive. And if somebody was to say to you, if I keep my head forward and I strain my neck muscles in order to breathe, I'll have pain in my neck, a chronic pain in my neck. Let's see, what would I rather do, breathe or have pain? There's no choice because our brain makes that choice. So if there's
weird that people would do that. It's just amazing that people would do that, I guess.
Well, you ever hear the story about a kid who's mad at their parents and say, I'm going to hold my breath until I die? It's impossible. You cannot you cannot force yourself to stop breathing. And so like people can go to do body work or see a chiropractor and they say, I have the most wonderful chiropractor in the world. I always feel good when I leave that office, but the adjustments don't hold. Well, the adjustments may not hold because there's an underlying airway issue and patients and the brain says, if I keep my head and my neck muscles relaxed and I hold that position that the chiropractor put me in, I'm not breathing well. I mean, we see that all the time with connections throughout the whole body. I mean, we look at patients, their gait, how they walk. Are they listing to one side? Are they favoring one side? The relationship of jaw position and bite is fascinating. I work with my son, who's doing a research project with Weill Cornell Medical Center using oral appliances treating Tourette's patients, and the study's just about to be published, and the results are excellent because if you think about it, and we believe that it's an underlying airway problem, that if I came up behind you and put my hand over your nose and mouth and didn't let you breathe, you would be screaming and kicking and cursing, and we can measure that with something called heart rate variability, which measures the physiology of the patient, which looks at how we go from the more sympathetic or yang state to the yin state, and people who are Tourette's patients tend to be stuck in more that adrenaline, sympathetic, upregulated state. Even though we seem to get more done because we have more energy, it's not the most efficient state to be in.
So how do you approach fixing when you look at someone's airway or all the ancillary problems that can happen? Is the first go-to to do a sleep study and then like optimize their sleep 100%, or what? How do you begin to make headway with all these situations?
Okay, so life is simpler where you just do a sleep study and say, okay, they qualify for an appliance or don't. But looking at things from a more collaborative approach, you say, all right, what's going on? Does the patient have several problems, health problems that need somebody else in the picture? Because collaboration should be done at the very beginning. You want to build a team for that particular patient, and so that team may include a dentist, may include a physician of different specialties, may require a physical therapist or a myofunctional therapist or a nutritionist. So what we do in our office, we do a very thorough health history. We look at their blood chemistry. We want to look at inflammatory markers to see whether or not they have chronic inflammation, and we look at their periodontal health, which could be an indication of inflammation and sleep problem. And then I know that your podcasts are involved with tech. One of the most wonderful things is these three-dimensional X-rays called cone beam CAT scans, where we can actually get a measure of the airway, looking at the in three dimensions. Of course, what you see on the X-ray the size of the airway doesn't really tell you how much effort that person is expending in order to keep their airway open. So somebody could have a very small airway, but they're not working hard to maintain it. Somebody could have a large airway, and then you can see on the X-ray the back of the tongue is distorted, that they are working 24/7 to keep their airway open. And they also have a very straight, almost like a military, they call it military neck. So keeping their neck straight and their tongue forward, having constant muscle tension is the way they keep their airway open. And as soon as they would relax, the airway begins to close. So these are people that their brain says relaxing isn't a healthy state to be in. So cone beam CAT scan is a great tool. And then the other thing that we do is we do what we call physiological monitoring. So it's instrumentation that we do an EKG respiration rate by putting these belts around the chest and the abdomen, so we can measure the rate that people breathe through their upper chest and through their abdomen, and we want to see whether they're breathing more. And we take the data from that with muscle contractions, EMGs, and we get a printout of what their physiological state is. And then when we alter the jaw position, whether it's for a TMJ appliance or for a sleep appliance or for an athletic performance appliance, we look for changes, objective data in the physiology. That's how we determine where we're going to place the jaw for optimal results.
Well, let's talk briefly about TMJ. Where do you believe that TMJ stems from? Or what are some of the places it can come from?
I think that almost the vast majority of TMJ problems come from an airway problem. I can't remember the last time I saw somebody with a TMJ problem that didn't have a underlying airway problem. Because whenever you have an apneic event where you stop breathing, and on a sleep study, a bruxism or clenching event precedes every apneic event. And if you're having 20, 30 an hour, you're having apneic events. So we see a distortion where muscle contractions uneven, there's wear on the condyle, one jawbone greater than the other. And if this goes on for a number of years, you begin to get alteration or derangements within the TMJ anatomy. The disc gets out of place, and now you have this imbalance, which adds further stress to the system. So, in answer to your question, I think the number one cause of a TMJ problem is an airway problem. So
again, it's the airway is compromised. So the body is, tightening muscles, moving things, trying everything it can to restore the airway.
What wouldn't you do to breathe better or to breathe adequately?
I understand.
Anything.
It's just funny that, again, my perception, not knowing, is like I'm walking around and breathing fine. Why would my body need to do all these things to improve my airway? And consequently, when I look at other people, I would think that they probably think that they're breathing okay, or I don't know. I mean, I guess it seems subtle, but the effect is not subtle at all.
Right. That's exactly the point. That everybody, I know that when anybody comes into my office, I know they're breathing, but we don't know the effort that they're expending in breathing. So you look at children. What are the signs of an airway problem in children? Poor learning, bedwetting, increased allergies, but they're breathing. They have circles on their eyes, their mouth is open, they're breathing, they're putting more effort into breathing. You treat their sleep, you do some changes in their growth and development if it's early enough by doing expansion orthodontics, and lo and behold, their scores go up in school. Bedwetting stops. They were breathing before, but they were breathing with compensations that affected them. And so that's the challenge of looking for these underlying problems. We have I mentioned our foundation. we've created this Global Airway Health Day, which is going to be October 2nd. Now, why do we pick October 2nd? Because October 2nd is O2, which is oxygen. And our goal is by 2020, we want to help 1 million people a year recognize an unrecognized airway problem. We now have, and we think this campaign is a partnership of the public, practitioners, corporations, and organizations. And every week we have more of each group coming on board to support this project. We have on our foundation website, which is airwayhealth.org, we have success stories, people whose lives have changed dramatically just by recognizing and treating their airway problem. We've created that as a free resource to the public and to practitioners to just go and learn more. We have a free sleep inventory where anybody can go take the inventory. It gets assessed by somebody, and it will determine their risk factors. And once you're screened, then you can take the appropriate measures to do something about it.
Okay.
I think that's the most important thing. If I have one message for this podcast, it's that yes, everybody's breathing. I don't think I have a problem, but you need to look at, do you have factors that are showing that you're breathing with difficulty, with compensation? Is it affecting your immune system? Do you have inflammation? Is it affecting your life? Because what you do about it today will affect your health 10, 20, 30 years from now.
Quick question I haven't asked. What about asthma? People that have asthma, what kind of compensations do you see that they make? That seems like a more blatant or obvious issue with the airways.
Okay, so let's say somebody has a small airway. A small airway means that you breathe more rapidly because you don't take as much air in with each breath. And when you don't take enough volume of air in, you don't exchange the air as well. And so tend to be a mouth breather. So if you're a mouth breather and you don't exchange a full volume of air residue collects on the bottom of the lungs. Irritants, pollutants collect on the bottom of the lung. And in addition to that, you have an upregulated nervous system, immune system, which is going to have an exaggerated immune response. And so even though asthma is a separate disease, often treating the sleep problem, if there's an underlying sleep problem, or doing something to increase the airway, will actually improve or eliminate asthmatic problems, and that's been seen in many patients. I mean, you can just look at the research, sleep and asthma, a combination of how that goes together. Same is true for sleep and allergies. Now you have to understand that the whole branch of sleep medicine is so new. It's only existed for, the first CPAP was in the 90s, and that was the back of a vacuum cleaner. That's how the first CPAP was created.
A quick question in a sleep study, they're just looking for a certain duration of someone stopping breathing, for apnea events, so they get 10 seconds or longer, and a certain number per hour. Are they, if you do a sleep study, do they just say, "Oh, you're fine, you don't have apnea," or do they tell you exactly what they observed and help you look at other aspects of your sleep that may be causing you a problem? Or is it just like yes, no, pass, fail, throw you out in the street and you're fine?
Well, obviously, depending on who you go to, the test could be viewed as different. But if you're looking for a diagnosis of apnea, then it's all based on how many times you stop breathing.
No, I don't mean not just apnea, but do most places that do sleep studies, it's either apnea or no apnea, and that's it. Or do they look at other elements of sleep? In the sleep study, is there a lot more to learn besides apnea, no apnea?
There's a lot more to learn. I'll give you a quick story. I have apnea. I've been using a oral appliance and or a CPAP, combination of the two, depending upon what my needs are. I needed to get a new machine. I went for another sleep test, and they said, well, in order for us to approve it, insurance to approve it, you have to do the first part of the study without anything. I said, I have not slept without anything for 15 years. And so after 4 o'clock in the morning, I said, so what's happening? They said, well, you don't qualify because we haven't counted enough of apneic episodes. I said, yeah, I haven't slept all night. So I went down to my friend who's a sleep doctor in Houston, Texas, put me in his lab, gave me a little sleeping pill, and they used something called the PEZ. It's a little thing they slide up through your nose down in your throat. It measures airway resistance, and it can actually detect the collapse of the airway. And in 30 minutes, they had enough data in order to fit me for a new up-to-date CPAP. So it all depends on the center and what they're looking for and how well trained the person running that is. You know, by measuring up airway resistance, if you were sucking something through a straw and I squeezed the straw, what would happen to your cheeks? They would sort of get sucked in, right?
Yeah, they collapse.
Yeah, that's negative pressure. When we have our airway collapses, one of the things that happens, we get that same sucked in thing happening to our chest wall, which pushes pressure against our heart. And that slows or may even stop the blood flow from our heart. And then when that moment passes and everything relaxes, that blood that's been stored up and pent up gets released with greater force. And that's called turbulence. And turbulence causes bumps up against the walls of arteries and causes inflammation, mechanical inflammation. It also, right? You know, if you think about water coming down a stream, or you're in Austin, Texas.
Yep.
Yeah, so you probably get like flash floods and things like that where it rains and then the sides of the gets eroded by the water coming. So and especially where a blood vessel divides in two, you get more irritation in that area, and then the body says, look, I got to do something, and it puts a bandage over it, which tends to be lipid or fat or cholesterol deposit that it covers over with a calcium deposit, which is plaque. So just a mechanical effect of what we call upper airway resistance, where you get these negative pressures building up with what they call intermittent hypoxia, where you breathe more or less, is enough to start that whole process of inflammation, and which is the seeds of heart disease, which again can take 20 or 30 years. And also, the other interesting thing, when that happens and there's pressure against the heart, the brain believes that there's fluid retention, and it releases a protein which tells the kidney to get rid of fluid, and that's why people wake up in the middle of the night to go to the bathroom. So when people say, like, do you sleep through the night? Well, I sleep. The only reason I get up 2 or 3 times to go to the bathroom. So I said, well, you get up. Let's say you get up every 3 hours, 2 or 3 hours. Says, yeah. Did you have to go to the bathroom as many times during the day? No. So what's different at night? And when their sleep is treated, all of a sudden they find they're getting up once or maybe not at all to go to the bathroom. Same thing. That's the same thing that happens with bedwetters in children, where when you treat their sleep, you don't have that airway, that negative pressure, and the release of this protein, which tells the kidneys to empty. Our body's the most incredible thing, that when everything works, it's fantastic. The miracle is how everything works. Every millisecond, our body and our brain is monitoring everything that goes on inside our body and everything that goes on outside our body, and is making minute adjustments when we walk and we shift our weight from one foot to another, when we when we chew or we turn our head and we lean over to get something and we don't fall over, our muscles are changing instantly, like the way our autonomic nervous system works. I'm on a plane lands, I go to get my suitcase. The moment I think about reaching up to get my suitcase, the blood vessels that go to the muscles that I will need to do that action dilate and send more blood and oxygen to those muscles, and only those muscles, and it happens in a fraction of a second. And so getting back to what you said before, well, I'm breathing, it's hard to realize it, but if you think about, well, I have to make a compensation because, I have to do things a little bit differently, so you're not efficient. I liken it to you have a car, it runs really great, it's fine. You go over a bump and things are a little bit out of alignment, you still get from point A to point B, but the ride isn't as smooth, but it doesn't matter, you're still functioning. And pretty soon you forget how good your car was when everything ran well, and because it's still functioning. Same thing happens to our bodies. The only difference is some people never had their body functioning well, and they have nothing to compare it. They have nothing to compare it to, and so they are the ones, or they may be just like everybody else in their family who has the same problem. And what's the big deal? My parents didn't sleep well, and my family all have similar problems. But we are a society that's unhealthy, and we have ways that we can reverse that. But we have to look at the things that aren't working.
Well, Howie, we're out of time, but this has been like a really great call. A lot of new things that I've thought about. What's the best way for people to find out more, to get in touch, or to visit one or both of the organizations you've created or work for? So
if you are a practitioner, you can go to the AAPMD, which is www.aapmd.org, www.aapmd.org. Even if you're not a practitioner, there's a lot of great information on there. If you want to go to the foundation, it's airwayhealth.org, www.airwayhealth.org. And because we're doing this O2 campaign, Global Airway Health Day, we are encouraging everybody, whether they be a practitioner or just a member of the public, a parent, a teacher, a nurse, to become an airway advocate, learn how to recognize an airway problem. I think that just from our discussion, you are more aware of unrecognized airway problems, and you can be an airway advocate. So I would encourage you to go to our website, sign up yourself, and be part of our army of airway advocates to fight this epidemic.
That's great. Well, Howie, thank you so much for coming on the podcast.
You're very welcome, and thank you for having me.
You're listening to the Future Tech Health Podcast with Richard Jacobs. Until I reached age 40, I never realized the obvious, that we all have medical issues, or we at least have a family member or close relation that has, or will have them in the future. Medicine and biological systems are the final frontier. Until we've conquered death, figured out how life began, cured cancer, and understood our purpose in the universe, there's a heck of a lot to talk about when it comes to our health. Future Tech Health means I'll be covering futuristic topics that are actually already in clinical trials, or even starting to appear on shelves or by prescription, or available for your own use. We dive deep into stem cells, CRISPR-Cas9, the science of sleep, epigenetics, medical testing, cancer, ketogenic diets, stem cells, aging, regenerative medicine, and more. My goal for you, the listener, is to learn from these podcasts. You may very well learn something that may change the course of your life for the better, steer you towards a new career, or give you insight into addressing a serious medical problem. Remember, however, this podcast and its content is informational in nature only. No medical, tax, legal, financial, or psychological advice is being given. If you enjoyed the podcast, please listen, subscribe, like, and share it with friends. Thank you.